Thank you. So we'll have our next speaker now. It will be presented by Dr. Youssef Nu'man. All the questions will be taken after the next lecture.
Bismillah, alhamdulillah, wa salatu wassalamu ala rasulillah. Our next speaker is Dr. Xenophon Barayakos. Dr. Xenophon Barayakos is a very well-known expert speaker. He was specialized in orthopedic surgery, and now he's specialized in internal medicine, internal rheumatology, and now he's the head and the consultant of the scientific coordinator of the Rheumatology Center in Ruhr University of Bochum in Germany. Dr. Barayakos will talk to us today about the recent advances treatment and strategies for a better outcome and quality of life for patients with ankylosing spondylitis, which is the treat to target new philosophy. So he has many awards actually. We don't have time to mention it, but I think he's well known, and he doesn't need to represent him more than that. Dr. Barayakos.
Without losing too much time, I will go directly into my presentation. And first of all, I would like to thank you for inviting me to speak to you today. So my topic was spondyloarthritis and the achieving treat to target issue, which we all know is something that may be, let's say, a principle that has been published years ago, but still is something that we all see in all recommendations that apply or that are being produced and published. So I'm having a look at the time here so that we also stay in time. I will try to be precise and also on time. So again, I go back one slide. Treat to target, can we achieve it? And secondly, if yes, how should we do that? We should do that, obviously, based on these recommendations by aiming for remission. That is a target that has been published so far. And aiming for remission is not just one time of remission, it is a long time being on remission. This means sustained remission. And this should be measured, for example, in spondyloarthritis, in axial spondyloarthritis by the ASDAS, or in psoriatic arthritis by DAPSA and MDA. And if that target is not possible, then the other target should be the least disease activity that is possible, which is also sustained. And as you mentioned, quality of life and also other things that apply to the entire spectrum should also be considered. This means exarticulate manifestations, comorbidity, and so on. So this is my topic today. How can we achieve all this? And can we achieve all this? One thing that I would like to remind you is that we also need to take into account daily practice. And daily practice is based on recommendation. This is now for the axial spondyloarthritis recommendation. And the question that I pose here is, what is successful treatment? So what is the treat to target principle? I believe that taking into account the biologic DMARD treatment, because this is what people really concentrate a lot on, but also the step before, which is the non-steroidals. This is always the case where I have a treatment, any kind of treatment, which should be continued, which can be continued over time, again, by having the patient on the target, which should be low disease activity or remission. I take now remission as the ultimate goal of the treatment, and this should be continued over time without any clinical issues. This means no adverse events, no loss of efficacy, radiographic damage should be considered in there. So the continuation of the treatment, that may be one part of the successful treatment option that we have based on the recommendations we're using every day. So how can we measure it again? Again, I told you ASDAS or maybe even BASDA is something that is taken into account as a measurement. Others say that successful treatment is, as I mentioned before, the long-term treatment without loss of efficacy, and obviously also persistence on the drug, or the remainder on the drug, no changes, no switches on the drug. Here I present you data that we just published, that we published longer ago on a long-term treatment outcome. And again, what I'm taking out of this is that our patients stayed on the same drug for 10 years. Okay, now you can take BASTA, you can take ASDAS, CRP, you can take function, mobility index. All of them didn't really change much. That could be, for example, the treat to target as we applied in daily practice. One other thing that we can also say that this is the definition of successful treatment and on treat to target is the outcome of radiographic progression. Here I show you data where at baseline patients were evaluated regarding their radiographic progression measured by the EMSAS over 4 years. And you see that we found that, again, at baseline, the situation was that if you have a high CRP, then you have a faster progression or a higher progression over 4 years. As compared to low CRP at baseline, then you have a lower progression. And the target would have been to stop that progression rate. And we have been able to show that after 2 years of treatment, so this means the half time of this period, if the patients went down with their CRP, this means systemic inflammation goes down, and obviously they stay on the drug. This means also they have clinical benefit. Then significantly, that's a p-value, significantly also lower radiographic progression was shown 2 years after. This means at 4 years. As compared to those patients who had high CRP, they maintained the high CRP, they had radiographically more significant progression, which again means successful treatment, treat to target, may also be that we measure it by systemic inflammation markers and radiographic outcomes. Or another thing would be that we say, well, successful treatment is that I diminish inflammation, whatever it takes. For example, by showing that the initial inflammation on the MRI goes away, and this is after 1 year, or even it goes away after 6 weeks, okay? So there's many different opinions about what treat to target is. Again, we have the treat to target strategy, the publication, the principle, but we also have our daily practice information and application of our treatment goals. And they may be different between physician and physician or between patient and patient. And that's something that, again, I would like to make you aware of when I speak about the data later on. How do we measure the target? How do we measure, for example, remission? There is different criteria to use. We have the other partial remission criteria. I have to be honest, we don't apply them in daily practice. I'm not doing the ASAS partial remission status in all my patients. Of course, I do the BASTA and the ASDAS, and that's it. But remember that the study data that we have to define our targets have been obviously collected by those kind of criteria. They include patients' global assessment, pain, function, and inflammation. This means, in fact, here, morning stiffness in the lower back. This is what the studies have shown us. Or we are also using the ASDAS, which is the newer score, which includes BASDAI questions and also patients' global and CRP. You see here, CRP would be included in the ASDAS as a part of the objective measurement of systemic inflammation. So these are things that we are taking into account. This is something that we do in daily practice. Other studies may also have included as partial remission in there. And the good thing about the ASDAS is that it also has cutoffs for status. So that's again where we can measure and we can compare the status of today as compared to the status of the last time of the last visit in daily practice. Excuse me. And here we have an active disease, low disease activity, high and very high disease activity statuses. And that's something that we, of course, also again keep in the back of our head when we maybe change the treatment or feel the need to change the treatment. This means again not sustained in a situation. In case the patients change from an inactive status or low disease activity status to the high ones. I would like to remind you that, of course, this also applies to psoriatic arthritis. So I will be focusing on axial disease now, but also psoriatic arthritis has targets for treat to target, also for remission. For example, using the DAPSA, which is also something that has different cutoffs and different statuses. And we also have the MDA, which is a yes or no answer. This means either I achieve MDA. This means I achieve 5 out of these 7 parameters. I will not go into details because of the time, but I would just like to remind you that also in psoriatic arthritis, there are similar approaches of how to deal with treat to target. Now, if we talk about treat to target as and the ultimate goal being remission, the question is, okay, we have defined that, that's in the protocols, that's in the publication, but does that really matter? Okay, do we need to hammer remission into the patient, and what do we achieve by that? Well, we've seen that by achieving remission based on the ASDAS below 1.3, this is low disease activity or remission, there we do not only achieve the continuous status clinically, which is what treated target says, but we also achieve the fact that lower proportions of patients progress radiographically. So by achieving the target, we indeed also have a benefit for the patient radiographically. As compared to not achieving the target, that's no remission, there more patients progress radiographically. We can also achieve the low disease activity. Also here, lower proportion of patients progressing radiographically as compared to those who do not have low disease activity, more patients progress radiographically. So does that matter? Yes, it does matter, because not only the clinical, but also the CRP, which is included here, and the radiographic progression, they are all being affected positively. So all the topic that I'm discussing here, I just showed this by this one slide that it does matter clinically. And by the way, also the same is there for psoriatic arthritis. Those patients who achieve MDA, and again, not in just one visit, but in more visits, 3 or 4 consecutive visits, they have less radiographic progression. So they're not only benefiting clinically, but also radiographically, as compared to those who do not achieve MDA, they progress radiographically. This is now in different scores, different arms of a study as one example, okay? So these are the data with golimumab, placebo to golimumab. MDA was beneficial. Being on golimumab from the very beginning, MDA was similarly beneficial. So all the same is also for methotrexate. So it's not the treatment, it's the target which indeed shows the benefit. And therefore, I would indeed suggest in daily practice to try to achieve it as good as possible, because the patients benefit also secondary by being in continuously low disease activity statuses or even in remission. Now, the next question is how many patients can reach that goal? So we agreed that there are ways to measure remission. We know what the target should be. We have agreed that based on this data that I showed you that it's also beneficial. But the main question is now, is it realistic? How many patients can achieve that? What I show you here is a study that we did with NSAIDs, the first part of the treatment in spondyloarthritis. And we've seen that, let's say, ASDAS partial remission or ASDAS below 1.3 or BASTA below 3, there are many patients who will reach that. ASDAS partial remission will not be reached by so many as compared to the other two outcomes. Here after 1 week, here after 4 weeks. We can take these numbers and compare them. This partly has to do with the fact that the advanced patients with ankylosing spondylitis especially will not reach a very low BAS-Phi level because of the advanced disease, and BAS-Phi is being included in partial remission of the ASDAS definitions. But if we take the low ASDAS or the low BASTA cutoffs, we see that every third or almost every second patient may reach that. So obviously, it's not so unrealistic that patients already after 4 weeks, not long after initiation of treatment, will be having a good outcome, which again will make them benefit also radiographically and continuously in the treatment, in the disease course. And when we look at the biologics or the JAK inhibitors, I know it's a busy slide in terms of numbers, but you can look at these deltas. This is the difference between the active drug and the placebo. They all lie somewhere between, let's say, 20-something and 30%. That's ASDAS 40. This is low disease activity. We can take also remission rates. This is about, well, with 1 or 2 exceptions, this is about 10 to 20%. This is now ASDAS partial remission, and this is ASDAS inactive disease. This is also somewhere there. I wouldn't really make many differences, by the way, between the two different studies, because the one is a phase 2 study, the other is a phase 2/3 study. There is different study designs. Nevertheless, what I want to say by that is that both with NSAIDs and with biologics and with JAK inhibitors, we are able, within a very short time period, after a couple of weeks only, to put patients in remission, and continuing the treatment, these numbers will also improve additionally. So I'll just go back a little bit. It is realistic to have the target, maybe not in every patient within, let's say, a couple of weeks, 4 to 8 weeks, but looking ahead, we are able to either reach low disease activity or remission in many patients. Now, the other question is, can we predict the target? Can we predict remission, for example? And the study, which was published longer ago, has shown pretty nicely that It's not that, you can take one parameter and say that if the patient has that parameter positive, he of parameters. And I will show you what, at least in my opinion, the most important one is. What they did here was to create a heat map and plot the probability for achieving remission after 6 months, which is, to me, mid-term. And they plotted BASFI, they plotted age, B27 positivity or negativity, which is a predictive marker also genetically for maybe more severe disease, and CRP. And they found that, for example, if you have a young patient, even without high CRP, and with normal BASFI based on disease activity, or functional impairment due to this activity and B27 positive, then you would, for example, based on these calculations, have a probability to be in remission of more than 30% after 6 months. If you change the patient and you say, well, the patient has high CRP, also high BASFI, but he or she is older, so you go beyond 40 years, then the probability would drop down to about 8%. This means lower than 10%, which to me shows that in this combination of different parameters, and this is daily practice, you don't have one type of patient only. Age, or let's say the earlier the diagnosis would be set, the better would also then would be the probability, the higher the probability would be for achieving remission. And that's something that I indeed focus a lot after having seen all this data in the last couple of years. The earlier the diagnosis is being made, the much better for the patient for treatment effect, also achieving the target, which may be indeed remission or low disease activity. And this also has to do with the fact that the earlier we start the treatment, because we have made the diagnosis earlier, the better, the faster the patient will respond. And this fast response within, for example, 3 months will lead to lower BASDAI. I just take BASDAI here as an example, BASDAI levels within 3 months. And the lower the BASDAI will be at 3 months, the much higher the probability will be after 8 years to be in remission or to be in low disease activity or a good responder. If the patient starts the treatment later, then the disease activity improvement within 3 months will not be so good. And therefore also the probability to be after 8 years, you see that here, in a low disease activity status will be lower. And in contrast, the probabilities to stop the treatment because of inefficacy will be higher. So altogether, I bring it to the point or to the summary that I say that we can achieve the target. It's not unrealistic, but we also need fast diagnosis, fast referral to the rheumatology, and also fast treatment. It doesn't have to be a biologic. It can also be an NSAID, or if the NSAID is not responding, then the escalation to biologic is there, because the faster we do this whole process, the closer we get to the treat to target principle, which is again low disease activity or remission. And this needs to be ensured for a long time period. Here we analyze the data after 8 years. Now, other things, and I see that time is coming to an end. But I have a couple of minutes to just finish that up. We also need to take into account that there is also other reasons to not be in remission. And these things are things that everybody is exploring nowadays. For example, males and females. We know that female patients may have lower chances to be in remission as compared to males for maybe hormonal reasons, maybe other reasons we do not understand. This was in partial remission in an Italian study. These are the data from Switzerland, which have shown the same thing, ASAS below 1.3 or even ASAS 20, so the not so tough parameters to reach. These are all significant between males and females, and therefore, again, also, for example, there might be differences in gender, or there might be differences in other concomitant diseases such as secondary fibromyalgia, which may also occur in chronic disease, which is being undiagnosed. Therefore, I say early diagnosis is important, because there you see here the p-values between fibromyalgia, secondary fibromyalgia, yes versus no. Those with no are better, those with yes are worse, and this is again also statistically significant. Now, one last thing that I think is also important in this topic is whether or not by achieving the target, we should continue, or are we able, or are we flexible also to change our treatments? And one thing that I would like to remind you is that there is a recommendation saying that in the ASAS-EULAR recommendation, saying that biologic DMARD tapering can be considered if a patient is in the target. This means in sustained remission. Can we achieve that? Well, we know that, and this has been published really long ago, we know that if we stop our treatment in patients who are in low disease activity, here we did it after 3 years, all the patients, this was done with an anti-TNF at that time, all the patients will worsen. So we cannot stop the treatment. If we retreat the patients, then the patients will go back to where they've been before, but stopping is not an option. Especially it's not an option in patients with established ankylosing spondylitis. On the other hand, we know that in non-radiographic axial spondyloarthritis, in the earlier form, if the patient is in remission, this was time point 0, so we achieved the target, and we stop the treatment, then this will also happen. Many patients, significantly more patients, will lose their efficacy. There will be also some of those who continue and they will lose the efficacy, but this difference was significant. This means indeed stopping is not an option, also not in non-radiographic spondyloarthritis. However, these patients who lost efficacy were still just a few. This means about 50% will not lose their efficacy, which is different from the radiographic stage. You remember there, everybody lost the efficacy. So in non-radiographic, this means in early treatment, we also have that process, but it takes longer, which I believe emphasizes that early treatment effects also allow us to, let's say, play a little bit more around the treatments that we have. Remember, in non-radiographic axial spondyloarthritis, nevertheless, we have the limitation that if somebody loses efficacy after stopping and we retreat, their achieving it may be a little bit more difficult. So you remember the data with ankylosing spondylitis, all of the patients achieved the previous treatment effect. Here we lost some patients, about 40% at least after 12 weeks, which again makes things a little bit more complicated. I will not go into too many details here. I just want to say that non-radiographic and radiographic may behave a little bit differently. Nevertheless, and that's in fact the end point of that, we may be able to reduce the dose. So standard dosing means continuation of the dose as compared to reduced dosing. This means we slowly decrease the dose. It did not lead to any significant differences between the groups after 1 year. This means stopping is not an option, reduction is an option, and the reduction may also lead to less costs without losing efficacy. And how can we do that? Well, we can do that by, for example, tapering slowly. Tapering slowly means after 2 years, those who tapered 25% of the dose had lesser flares as compared to those who tapered 50% of the dose. They had more flares, but lesser than those who stopped. So slow tapering, as slow as it gets, even over 2 years, makes sense. And this has also been published in this very late stage study where the one drug was then spaced from 2 weeks to 4 weeks at the same dose. Here are those two graphs. There was no difference. The patients, again, as a confirmation, the patient who stopped, they lost efficacy. When the patients were spaced over the double the dose over 1 year, they did not lose efficacy. So altogether, again, spacing or reduction of the dose is an option, but stopping is not. And therefore, I conclude, we need to reach a target. We need to reach remission or inactive disease. We have patients in inactive disease statuses without loss of radiographic progression so much. Those who are not reaching the target, they are not only not reaching the target, but they also have higher radiographic progression. That's what this shows. And therefore, again, the plea, early diagnosis, early treatment, long-term sustainability. This is how we can indeed reach our targets. Thank you very much for your attention.
Thank you, Dr. Barayakos. So now we'll see if there's any questions from the audience. I have a question to Dr. Choi. In regard to the JAK inhibitors, is there any difference? Do you think there's difference between the rate of thrombosis between the different JAK inhibitors that we have in the market right now?
I don't think it's possible to compare at this moment in time.
Okay.
One is that the events are quite rare, so I don't think that any analysis will have the statistical power to compare between the JAK inhibitors.
I see. And in patients who are don't achieve remission, for example, in some of the JAK inhibitor, is it do you have any experience between switching between the JAK inhibitors? For example, if patient failed tofacitinib, do you think it's useful to switch to another JAK or go to another class? Yeah.
Yeah, I think there are reports that switching amongst the JAK inhibitors can work. And obviously, if the JAK inhibitors have different selectivity, that may be one explanation. I mean, the other obvious explanation is that the metabolism of JAK inhibitors are very different. They have different absorption rate, they have different metabolic rate. So those differences can influence the efficacy.
I see. For Dr. Barayakos, you have mentioned that...
I have a question.
Yeah.
Go
ahead, yes.
I have a question. So Ernest, do you believe that selectivity plays a role? The one may be more JAK1, the other one may be less JAK1 selective. Would that make a difference between the compounds?
There is definite scientific reason to believe that selectivity plays a role. So given that you asked the question, I will say, if there's a disease that is influenced by IL-23, JAK inhibitors can inhibit IL-23, but you need to influence the JAK2 isoform and possibly the JAK3 isoform to achieve that. So that's where really some of the major difference is going to be.
Sorry, thank you.
Okay, sure. Dr. Barayakos, you mentioned that it's difficult to achieve remission in patients with axial SpA or ankylosing spondylitis in female. Is there any explanation for this?
There's many pieces of information, but no clear explanation. I do believe that there might be a kind of hormonal difference in terms of how bone marrow edema occurs. We have been able to show that in a recent publication in the normal population. So therefore, there might be that the loading of the disease or the burden of the disease behaves differently between males and females because of the hormonal differences. The other thing is that we do not know whether or not or how much of these hormonal differences may be influenced by our treatments. So that might also be something to explore. Us and others are doing examinations in that right now. And the other thing is that without wanting to think in boxes only, but we do know that at least secondary fibromyalgia may be something which is more frequent for whatever reason in women. And we've seen that secondary fibromyalgia may also influence the responses. So there might be a combination of all this.
I see. And one of the slides that you have presented today showed that there is a difference between, in those patients who achieve remission, you showed us that those who taper the dose to 25%, for example, has better rate of continuous in remission than 50%. Is there a limit to the dose reduction or tapering in patients with AS or non-radiological axial SpA?
Yeah, because of the time, I didn't really go into all the details, but I think this question is absolutely fair. And also, I would answer it very clearly. The data so far show us that we can, of course, do whatever we want, but it makes sense to not go beyond 50% of the cumulative dose. This means if you have a standard dosing, then I would expand the interval up to 50% of the time between the doses. If you have a drug that where you can arrange a dose, then I would either reduce the dose or expand the intervals again. By the way, expanding the intervals is better than reducing the overall dose. For example, in infliximab, that might be the case. And I would always try to expand the doses, but not more than 50% of the recommended spacing.
So what is the recommended time? What is the maximum limit that you can or maximum
50%? Let's say if you give a drug every 2 weeks, I would go up to 4 weeks max.
I see. Okay. So
per injection.
Next question. Yeah. You can use one of the mic.
Yeah, it's working now. So thank you very much to all the speakers. I have a question to Dr. Barayakos. So say that you have a patient with ankylosing spondylitis or axial SpA who's on treatment, but still having active symptoms, despite therapy. You do MRI and he's got fat lesions. So would you actively change the therapy or not? Thank you.
So fat lesions are not, thank you, that's a really clinically very relevant question, and thanks for asking it. Fat lesions are not a reason to change the treatment, because what you see being fatty is something we cannot change anymore. We cannot influence it at all anymore. What is happening there is happening over. The earlier we treat, the less fat lesions we have. But if the symptoms are there, this is what I would try to explain first by the MRI. For example, are there symptoms which are related to SPA, or are they degenerative? And if these are symptoms that are related to SPA, then yes, I would change the treatment, but not because of the fat lesions only.
Yes. Next question by Dr. Osama. Yes, go ahead.
Dr. Ernest, thanks for presentation. Do you believe that there will be one day pure selective JAK1, JAK2, or JAK3, or TAK2, or it is difficult to be in daily clinical practice to inhibit certain JAK? And are you aware about any clinical trial, randomized clinical trial, comparing between different JAK or not?
Okay, well, the second question first. There is no clinical trial that currently directly compare the different JAK. In part, because all the current JAK inhibitors all inhibit JAK1. And JAK1 is the dominant isoform in inflammation, definitely for rheumatoid arthritis. So I think one of the reasons why they look pretty similar is that they are all inhibiting JAK1 albeit at minor different levels. But the way that the medicines were developed and dosed, they were all designed to inhibit JAK1.
It's okay, thank you.
Yes. Dr. Yusuf has a question. You can come.
Okay, quick question to Dr. Barayakos. You mentioned in the parameters in the remission in spontaneous arthritis or ankylosing spondylitis that the CRP or ESR, how much really you can rely on ESR because of its wide variations?
Yeah, you can rely on ESR in, let's say, about 10%. But this is always being taken into account simply because ESR you can have as a result within an hour, and CRP you need a couple of hours, let's say, or you do it overnight depending on the setting. Therefore, everybody is considering it, but I fully agree with you. We don't really take that so seriously.
Okay, thank you.
Okay, so thank you, Dr. Choi and Dr. Barayakos, for this informative and interesting lectures. And hopefully we'll see you soon in Saudi Arabia after the pandemic ends. Thank you very much.